Okay, start
Yeah.
presenting.
So, good evening, members. In today's gynecology case presentation, we have Mr. Tapan Saikia, who is a fourth year student from Guwahati Medical College, Guwahati. All the best, Tapan. Do well as usual. And today's mentors, we have Dr. Gauri, who is a MS OBG from JIPMA, and her friend Dr. Sunayana, again MS OBG from JIPMA, and consultant in Hyderabad, joining us as mentors. Also, we have another new mentor today, Dr. Sindhu NR, who is a MS OBG from KMC Mangalore, joining us with in today's session. Welcome to all the members, and over to you, Tapan. Please start the session.
Okay, sir. Good evening, everybody. Myself, Tapan Saikia. It's a Mr. from Guwahati Medical College. I'd like to present a case from the subject of gynecology, and starting from the patient particulars. Here is a patient, Mrs. MB, age 40 years, Islam by religion, hailing from Rongya, Assam, who is a homemaker by profession. She has studied up to high school with a parity index of P2L2 plus 0. Husband's age is 50 years. Years of marriage has passed 19 years. Her husband's occupation is shopkeeper. Last menstrual period occurred in 21st of February this year, and the date of examination was 11th of March, and date of admission was 11th of March, and date of examination was 12th of March. So, coming to the chief complaints, the patient presented to the OPD with the complaints of pain in the lower abdomen for the last 3 months, and a lump in the lower abdomen for the last 1.5 months. So, the history of present illness. The patient complains of pain in the lower abdomen just below the navel for the last 3 months. It was insidious in onset, progressive in nature, dull aching in character. It was relieved on over-the-counter medication and aggravated on physical activity. The pain radiates to the back. There is no diurnal or postural variation to the pain, and was not related to menstruation. The pain is not associated with straining or increased on food intake. The patient also complains of lump felt in the right lower abdomen for the last 1.5 months. Initially, it was size of a betel nut, which gradually increased in size till it reached the current dimensions. The size of the lump doesn't vary with cough, posture, or on strain. There is no history of constipation for the last 1.5 months associated with the swelling. It is not continuous, and it is relieved by laxatives. It is the consistency of and the color of the stool was normal, however. Uh, the negative history, there is no history of trauma prior to the onset of swelling or prior to the pain. There is no history of any menstrual flow abnormality or irregular vaginal bleeding. There is no history of urinary symptoms like retention or any symptoms of incontinence. There is no history of chronic leg pain or leg swelling. There is no history of any generalized distension of abdomen, breathing difficulty. There is no history of any lump or discharge from the breast or any axillary or any swelling in the armpits. There's no history of fever, nausea, vomiting, yellowish discoloration of skin, eyes, and urine. There's no history of any symptoms of masculinization. The appetite and sleep was normal. There's no history of significant weight loss or any weight gain. There's no history of easy fatigability. Till here, it is the history of present illness. Should I proceed forward, ma'am?
Yeah, can you? Okay, what are the masculinizing symptoms you will see in ovarian tumor?
Ma'am, there are certain symptoms as well as signs that can be elicited. There will be history of acne or history of hirsutism. Then there will be voice changes. Fat, there will be the distribution of fat in the body will change.
Change of voice.
Change of voice, yes, ma'am. And there will be a decrease in the size of the breast. There will be history of amenorrhea, on examination, clitoromegaly can also be found. These are the signs and symptoms of masculinization.
Okay. And why did you ask about yellowish discoloration of skin, eyes, and urine?
Ma'am, I wanted to ask about any sign if Ma'am, any involvement of the liver from any pathologies uh, regarding any tumor or metastasis, or any because of any other pathologies that can involve the liver as well.
Like why particularly in this case?
In case of ovarian cancers, they can metastasize transperitoneal transcilomically towards the liver, and then it can invade the liver parenchyma that can cause uh, obstructive symptoms and can cause jaundice.
Okay, but then you should ask about all things, no? Like you should ask bone pain. Okay.
Yes, ma'am.
Yeah, you have asked. Okay, history of lump or discharge for concurrent breast cancer. Okay. Chronic leg pain or swelling. Why?
Ma'am, if any tumor obstructs the venous drainage from the legs can cause edema and leg pain. All.
Okay. Okay, but it is common in malignancy. In advanced cases, any malignancy can cause DVT that can cause leg pain and swelling. Ovarian cancer is often associated. So, I mean, advanced ovarian cancer is most often we see DVT.
Yes, ma'am.
That's why. Okay.
Okay.
You should ask symptoms like abdominal bloating. Okay.
Yes, ma'am.
Nausea, vomiting. You have asked, but they are called GI symptoms. You should ask all GI symptoms in case of ovarian cancer. I mean, ovarian tumor. It's quite common. Constipation, bloating, diarrhea, discomfort, vomiting sensation, nausea. All these are symptoms of ovarian malignancy.
Yes, ma'am.
Okay. Okay. Proceed.
Okay. Coming to the past history, there was no history of any similar symptoms in the past. The patient is non-diabetic, non-hypertensive. There is no history of any significant medical or surgical illness requiring hospitalization in the past. Um, and coming to the menstrual history, the patient attained menarche at the age of 14 years. The cycles are regular, 28 plus minus 2 days. Last menstrual period was on 21st of February. A single menstrual period lasts for 3 to 4 days with moderate and regular flow of bleeding, requiring 2 to 3 pads per day. It was not associated with any pain or any clots during the menstruation. In the marital history, patient is married for last 19 years with husband's age 50 years and husband is a shopkeeper by occupation. The marriage is non-consanguineous. Coming to the past obstetric history, there's history of 2 pregnancy with 2 living both are living issues. There was no significant history regarding obstetric history. Normal vaginal delivery took place, and there was no complications either in the antenatal or perinatal period, uh, and the babies are alive and well immunized.
Okay. You have nicely put up the table. You could have also put breastfeeding in this.
Yes, ma'am.
How long did she breastfeed the baby for? But nice. This detailed history is important for other cases like prolapse or pre-obstetric cases. This case, it's okay. And you can ask whether the conception was spontaneous or was it with any ovulation induction technique.
Yes, ma'am.
Okay.
Shall I proceed, ma'am?
Tapan, are you
Yes,
following?
ma'am. Yes, ma'am.
Oh, okay. Next.
Coming to the family history, there is no family history of similar complaints in the. There's no history of similar complaints in the family. There's no history of any malignancy, ovarian, colon, prostate. I have asked regarding these specific malignancies in the family, and
Okay.
Coming,
Why have you asked all these specific malignancies which you have mentioned in the
ma'am,
here?
I have asked specifically regarding these organs, but in general, they don't have any history of malignancy.
Okay. You can also include gastric. It is known to cause Krukenberg's tumors of
Yes,
ovary,
ma'am.
no? Okay. Okay, next.
Coming to the personal history, the patient has a average non-vegetarian diet, 2 major meals, 2 minor meals a day. She doesn't consume any tobacco, alcohol, or betel nut. There's no history of any addictive substance abuse. Um, Coming to the drug and contraceptive history, there is no history of any contraceptive use for the patient as well as for the partner. And other than the occasional over-the-counter analgesics, laxatives, or antacids, there is no other significant long-standing drug history. Coming to the allergic history, there is no known allergy to any inhalant, ingestant, or contactant. Immunization history was cannot be elicited. However, the BCG scar was present. Coming to the socioeconomic history, the patient lives with her husband and 2 children, nuclear family. Husband is the sole earning member. They fall in the lower middle class family according to modified Kuppuswamy scale. They live in a pakka house with pakka kitchen and sanitary toilet. Source of drinking water is tube well, and it is consumed without any prior treatment. Cooking fuel is LPG, and there is adequate lighting and ventilation. Coming to the summary, 40-year-old P2L2+0 lady of lower middle class family with normal menstrual and past obstetric history as well as normal allergic drug and personal history comes with the complaints of dull aching, insidious progressive pain in the lower abdomen for 3 months and progressively enlarging swelling in the lower abdomen for 1.5 months, which is associated with constipation and no other associated symptoms.
Okay. You have not mentioned.
Hello, Tapan.
Yes, ma'am.
Oh. Ma'am, is it audible, ma'am? Mangala, ma'am?
Am I audible?
Yes, ma'am, you're audible, ma'am.
Okay. You didn't ask about contraception.
Ma'am, I asked, ma'am, there was no history of contraceptive use in the patient. Ma'am, I added in the along with the drug history, ma'am.
Okay. Okay, fine. Normal allergic drug and personal history. You need not mention all this
Okay, ma'am.
in your summary.
Yes.
Only significant things. Okay. And okay. Do you think pain is common in ovarian mass?
Is ma'am not common in ovarian tumor generally.
What are the common symptoms a patient presents with in ovarian mass?
Ma'am, there is an history of enlargement of there's a history of swelling generally. And
Yeah, that is the most common. Do they present with pain?
they do not generally present with pain at the early stages.
Okay, what are the causes of pain in ovarian mass, in adnexal mass?
Ma'am, if there is associated complication like torsion or any hemorrhage or infections in a cystic mass, or
Okay.
ma'am, if it is associated with other
Rupture of the cyst.
yes, rupture,
Okay.
then
Ectopic pregnancy.
Yes, ma'am.
Possible, right?
Yes,
But
ma'am.
not, yeah, they don't present with mass, but adnexal mass with pain, you can think of ectopic also. Then tubo-ovarian abscess.
Yes.
Okay. So what are the common symptoms? Usually the first thing that notice is the mass. Pain is not the earliest symptom. Okay.
Yes, ma'am.
They may have some chronic pelvic pain. It is common, but mass is more common than pain. Okay. Then, like I mentioned, GI symptoms, bloating sensation, indigestion, nausea, constipation, decreased appetite. Okay.
Yes, ma'am.
Okay. And you have mentioned about menstrual cycles, right?
Yes, ma'am.
Which ovarian tumors cause menstrual cycle abnormalities?
Ma'am, in case of tumors, ma'am, in case of tumors like granulosa cell tumors or ma'am, luteal cell tumor, then those can cause, ma'am, increase in menstrual blood flow, or in case of tumors like a Sertoli cell, Leydig cell tumor, or adrenal cortical tumor or hilar cell tumor that can cause amenorrhea.
Yeah, masculinizing tumors cause amenorrhea. Those which cause acne, hirsutism, they can cause amenorrhea. Granulosa cell tumors cause menorrhagia.
Yes, ma'am.
Okay. Okay. Otherwise, usually ovarian tumors do not cause changes in menstrual cycles. They are incidentally detected or they present with mass. You must have seen the pictures in your textbook of a large mucinous cystadenoma.
Yes, ma'am.
Grow up so huge, but they don't present with any. Okay.
Yes, ma'am.
So in your history, you don't know yet whether it's ovarian or uterine. So you have to still ask for menstrual irregularities because it can still be a fibroid.
Yes, ma'am.
Okay, fibroid can cause similar presentation, right?
Yes, ma'am.
Yeah, pain is common in fibroid, especially dysmenorrhea is more common, and there can be pain even otherwise, and menstrual irregularities are common. Mass is common. So you have to rule out fibroid also in this case.
Yes, ma'am.
Okay. What else could it be?
Ma'am,
What else? What else could it be?
ma'am, ma'am, it can be uh,
It can be a tubo-ovarian mass, abscess.
yes, ma'am.
That's why there could be pain.
Yes, ma'am.
Okay. She belongs to lower middle class family. Okay, poor socioeconomic status. It could be tuberculosis. Okay.
Yes, ma'am. Yes, ma'am.
Okay. Kishan? Kishan is there?
No, ma'am, sir is not there.
Okay, okay. What, I mean, could it be any other surgical conditions?
Yeah, yes, ma'am. Ma'am, in case of ma'am, ma'am, it can be any cystic lesions like mesenteric cyst.
Yeah,
Or it can
mesenteric cyst. And
ma'am,
it is in the, okay. Okay, it is which side?
ma'am, right lower abdomen.
Right. So you have to rule out lesions of right iliac fossa.
Yes, ma'am.
So your differential diagnosis includes all those which can be in right iliac fossa.
Yes, ma'am.
Tapan?
Yes, ma'am. Ma'am,
Hello, ma'am.
Yes, Hiranmai. Okay, hello.
Tapan?
yes, ma'am.
Hello.
Hello.
Yes, ma'am. You are audible, ma'am.
Yes, ma'am,
Okay.
you're audible.
Yeah, tell me.
Hello.
You're audible, ma'am.
Yeah. I asked you what are the DDs for right iliac fossa mass?
Oh, yeah, yes, ma'am. Ma'am, it can be due to any ma'am, pathologies in the appendix, like appendicular lump or appendicular mucocele, or any other similar diseases. It can be due to colonic involvement because of obstruction, or it can be due to any it can be due to irritable bowel syndrome that can cause lump in the right iliac fossa. It can be due
Okay.
to mesenteric involvement, etc.
And there is also one GI symptom, constipation.
Yes, ma'am.
That too with recent onset. Okay.
Yes, ma'am.
So, okay, next slide.
Coming to the examination, or in the general examination, patient was conscious, oriented to time, place, and person.
I want to introduce Sunaina. She has also joined now. Hello,
Yes.
Sunaina. Yeah.
Yes, ma'am. Yes, ma'am.
Is she there? Sunaina? She had joined, I don't know. Okay.
She was there, ma'am. I think she has left now. She was
Okay,
there,
it's
ma'am,
okay.
actually, a while back.
Okay, it's okay.
Yes, ma'am. She had joined, ma'am. Not a minute.
Okay. Okay, continue, Tapan.
Yes, ma'am. Ma'am, in the general examination, patient was conscious, oriented to time, place, and person. The build was normal, nutrition was fair. BMI was 21.25. Coming to our vitals, vitals were mostly normal. Respiratory rate, pulse, they were normal in rate rhythm
Okay,
as well as
next slide. This is all fine. Okay, next.
uh, coming to the head to toe examination, it was also normal. There was no pyloric just cyanosis, clubbing, lymphadenopathy, or edema. There was no signs of hirsutism or acne, and other sites were also normal. In the systemic examination, first coming to the abdomen examination, on inspection, there was a localized distension seen in the right iliac fossa, superiorly extending up to the paraumbilical region, but lower border was not appreciated on inspection. Umbilicus was pushed upwards and to the left. It was a bit everted, and respiratory movement is present bilaterally, and the skin moves over the swelling. There's no visible scars, pulsation, veins, pigmentation, rashes, or peristalsis over the abdominal skin. External genitalia and hernial sites were normal on inspection. Coming to the proper examination of the lump was elliptical in shape. It was in the right iliac fossa of approximately 11 to 8 centimeter in the perpendicular dimensions. It was superiorly extended up to the umbilicus. Inferior margin was not appreciable. The overlying skin was normal with no signs of any inflammation or any signs of any inflammation. Uh, it doesn't move with respiration, the mass. It doesn't increase on size during coughing or straining. On performing the Carnet test, it becomes smaller or when the abdominal muscles get taut. The temperature and tenderness there was no local rise of temperature or tenderness. The surface was smooth on palpation. Borders were felt superiorly and laterally well, and it was regular. There was no pulsatility. No pulsatility palpated. Uh, there was no compressibility or reducibility of the swelling. It was not fixed to the skin, and it was mobile. It was well mobile. The consistency was cystic, and the fluid chill was absent over the swelling. The percussion was dull and on auscultation it was silent.
Okay, very good. You have mentioned almost everything in palpation. But how did you elicit mobility in the vertical plane if the lower border was not made out?
Um, ma'am, I just tried to move the swelling to the direction, ma'am. It was Ma'am, I could move it well, ma'am.
Okay, you could push the upper border down, but you could not make out the lower border.
Yes, ma'am. It was a bit deep, so I couldn't make out the lower border.
Yeah, it may be posterior to the uterus. It is this vertical mobility you have to appreciate. If lower border is not made out, it is better appreciated on bimanual pervaginal examination.
Oh, okay.
Okay.
Yes, ma'am.
This I don't think it will be acceptable. You just say mass is mobile. Okay.
Yes, ma'am.
If lower border is not made out, you need not mention two perpendicular axes.
Okay, ma'am.
Okay. If both the border, all the borders are made out, then you can mention. But if the lower border is not made out, you just mention the mass is mobile.
Okay, ma'am. I understand.
Okay. If they ask in particular, then you can mention. Otherwise, while presenting, just mention that the mass is mobile. Okay.
Yes, ma'am. Okay.
Okay. Okay. Next.
I'm coming to the next slide, ma'am. On the other of the other sides of the abdomen, on palpation, the inspection findings were confirmed. There was no local rise of temperature or tenderness in the other quadrants of the abdomen. On deep palpation, liver, spleen, and kidneys were not palpable. On coming to the percussion, in the flanks and the epigastric region, there was tympanic sound was heard, and on auscultation, normal bowel sounds were heard over those areas.
Okay. See, how do you palpate? Do your palpation. If there is a mass, where do you start your palpation from?
Ma'am, normally we start the palpation from the left iliac fossa. However, if there is any site of pain, then we or pathology, we try to palpate from the opposite side of that, so that we can go from the normal side to the abnormal one.
Yeah. So in this case, how did you do it? Because you are mentioning it after the examination of the mass.
I did the opposite actually, but I wrote ma'am like that.
Okay, okay. So generally, you will be asked to demonstrate. So in
Yes,
that case, how do you demonstrate?
ma'am, because the mass was ma'am at the right iliac fossa, so I can continue in the normal way from the left iliac fossa.
Let's say patient was there beside you. Okay,
yes,
you were asked to see in examination practical, they will see how you do it rather than what you say. Okay.
Okay. Yes,
So if assume a patient is there, what do you do? Like you are asked to demonstrate examination, let's say. How do you do it? Let's say they will tell you, you demonstrate abdominal examination for this patient.
Okay. Ma'am, I'll first like to take a consent from the patient for the examination.
First, you should introduce yourself.
Yes, ma'am.
Okay, then you will take the consent.
Yes, ma'am.
Okay, then?
Ma'am, then I'd ask the patient to lie down on the bed, lie down on the table, and then, ma'am, I'd like to ask her to expose the abdomen in presence of another I'd like to expose abdomen, and for the inspection of the hernial side, I'd like to.
This empty bladder. You should ask the patient to empty her bladder.
Oh, yes, ma'am.
Okay. First is introduction, then consent, then you ask her to void. Okay.
Yes.
After that, she'll lie on the couch, and then you will expose the area to be examined, and you will cover her below that. Okay.
Yes.
These things all carry points.
Yes, ma'am.
Okay. Then you gently rub your fingers.
Yes, ma'am.
Okay. Then
then
this is the palpation. Before that, you will tell your inspection findings like you told. Then you gently rub your fingers and you start with palpation.
Yes, ma'am.
Okay. So where do you start from?
Ma'am, ma'am, I'll start from the left iliac fossa, and then I'll go upwards, and then coming towards the right, then I'll finally go towards the towards the site of the swelling.
Okay. Okay. The site of pathology will be palpated last, right?
Yes, ma'am.
Okay. Fine. Next slide.
Ma'am, in the PV examination on inspection, the vulva appeared to be normal on inspection. There was no signs of inflammation, discharge, or any ulcer or pigmentation, and there was no signs of any prolapse. On palpation of the vulva, it was normal. Inspection findings were confirmed. On further examination of the vaginal walls were normal on inspection as well as on palpation. The fornices were free on both sides, and there was no nodules or any mass were felt. The uterus was palpable and free from the swelling, but shifted to the left by the lump. The cervix was normal and remained stationary on pushing the swelling up from the abdomen. PR examination was not performed.
Okay, okay. Have you done PV examination, or is it given findings by your postgraduate?
Ma'am, I did not do the PV examination. Ma'am, they told me the findings.
Okay, okay, fine. Did you confirm with your abdominal findings from them?
Ma'am, I was present at the time of when they did the PV examination. Ma'am.
Okay, okay. See, you have told in abdominal see, you are not expected to do PV examination. Even if it's wrong, it's okay. You have mentioned in your this that lower border is not made out.
Yes, ma'am.
Okay. So how do you differentiate it from uterine mass? How do you know that it is ovarian and not uterine? It could be a right lateral wall fibroid of uterus?
Yes, ma'am. It could be.
So how do you differentiate?
Ma'am,
In your see, if you know the anatomy, you have mentioned fornices are free on both sides.
yes,
If
ma'am.
the ovarian tumor is on right side and lower border is not made out, you assume that the lower border is in the pelvis, right?
Yes, ma'am.
So you should feel it in the right fornix. If you're not feeling it in the right fornix, it is well in the abdomen and you can make out the lower border, right?
Yes, ma'am.
Okay, so this finding is little it is, I am not sure if it's correct. Okay.
Okay, ma'am. All right.
Okay,
Ma'am,
so how yeah,
ma'am, what shall be the findings according to this case, ma'am, in the PV examination?
I think right fornix is occupied with the mass.
Okay.
Okay.
All right, ma'am.
You should PV examination, it is for postgraduates. They don't expect you, but just for your knowledge, I am telling you,
Yes,
fornix will be occupied with the mass. If it is gone entirely into the abdomen, it won't be palpable. If it is very large, it won't be palpable. But small ovarian masses are felt in the fornix, especially if the lower border is not made out in the abdomen. Okay.
okay, ma'am.
And when you push the mass, see, you do bimanual examination to
Yes, ma'am.
make feel separate from the uterus. You should push the mass from above.
Okay,
You should see whether the cervix moves with the mass. If the cervix moves with the mass, then the mass is arising from uterus.
yes, ma'am.
If the cervix does not move, that means it is separate from uterus. Okay.
Okay, ma'am.
These two things you will note on bimanual examination.
Yes, ma'am.
Okay. You have written that cervix is normal, it remains stationary on pushing the swelling up from abdomen. So
Yes,
that
ma'am.
you have written, only thing fornix. Okay. I was asking you, what are the common symptoms which a patient presents with ovarian mass? In that, one thing is infertility.
Yes, ma'am.
In this case, it is not there, but so many times when you are doing scans for infertility on routine examination, you will find such a mass.
Okay.
Okay, that is also one of the, that may be the only symptoms. They may be incidentally detected on scan.
Yes, ma'am.
Okay. Next slide.
Yes, ma'am. Ma'am, coming to the examination of the other systems, the breast examination was normal on inspection and palpation. The other systems were also within normal limits. In neurological examination, no deficit was found. Cardiovascular examination, heart sounds were normal, and there was no murmur. On respiratory examination, bilateral equal air entry was heard. Vesicular breath sounds were heard. Shall I go to the next slide, ma'am?
Yes, next.
The summary, ma'am. A 40-year-old P2L2 plus 0 lady of lower middle class family with normal menstrual and past obstetric history comes with complaints of gradually progressive lower abdominal pain for the last 3 months, as well as progressively enlarging abdominal lump for the last 1.5 months, which was associated with constipation. On examination, 11 by 8 centimeters smooth cystic swelling was found in the right iliac fossa, which was mobile, non-tender, and not associated with the uterus.
Yeah, good. Not arising from uterus. Okay.
Yes, ma'am.
Mobile, non-tender, cystic. Okay, good. You have presented very nicely, Tapan. You have included most of the points. Very good. Okay, next.
Thank you, ma'am. Ma'am, coming to the provisional diagnosis, ma'am, it's probably a right-sided ovarian tumor, right-sided benign ovarian tumor, cystic cystic type with no complications.
Okay. So how do you say it is benign? What are the factors which can tell you that the tumor is benign?
Ma'am, benign tumor generally arises, ma'am, at the reproductive age group. It is a slow-growing tumor, and it is generally
One
slow.
second. You mentioned that it was the size of a beetle nut. Did you mention
Yes, ma'am.
that in
Yes, ma'am.
history?
Yes,
And
ma'am.
now it is 11 cross 8 centimeter.
Yes, ma'am.
Hasn't it grown quite fast?
Yes, ma'am. Ma'am, this tumor has, yes, ma'am, grown fast. Yes.
See, first of all, if it's the size of a beetle net, she won't be able to make it out, right?
Yes, ma'am.
That may not be correct.
Yes, ma'am.
Very small. It will be inside the abdomen in pelvis. She can't make out. Once it comes from pelvis to the abdomen, it would have grown sufficiently.
Yes,
It
ma'am.
should have been, I think, this was the size she has noted initially. Maybe some
Yes.
8 centimeter, it would have become 11 centimeter. That's what I feel.
Yes, ma'am. Ma'am, probably this is true, ma'am. She was also confused, ma'am, regarding the duration and the size.
Yeah, it is a slow growing tumor because small tumors are not appreciated even by physical examination. They can't make, patient themselves cannot make out at all. It was sufficiently large enough before she has noticed the tumor, and her age is 40. That is one
Yes, ma'am.
factor. So what age malignant tumors are common? Ovarian?
Ma'am, ma'am, generally at the premenopausal or postmenopausal, and ma'am, before menarche, ma'am, in the extremes of ages mainly.
Menarche, adolescent age, teenage, or
Yes, ma'am.
20s, initial less than like teenage and postmenopausal. So what
Yes, ma'am.
type of tumors? Do you know the WHO classification of ovarian tumors?
Ma'am, there are, ma'am, 9 categories, ma'am, of which the ma'am,
You tell the most common ones.
epithelial tumors, ma'am, within which there is
Epithelial
serous.
tumors are serous, mucinous,
Yes,
Brenner's, clear cell. Those
ma'am.
tumors are common in
Ma'am,
postmenopausal or
yes,
more than 50 years generally.
yes, ma'am. Yes,
Okay.
ma'am.
Then young patients.
Ma'am, germ cell, ma'am, tumors.
Yeah.
Ma'am, teratoma, dermoid cyst, ma'am, yolk sac tumors, and
Yeah.
ma'am,
Those are common in
young age, less than 20, or ma'am, similar.
teratomas. This dermoid cyst is also a teratoma. It can occur at any age. In young age, dysgerminoma
Yes, ma'am.
is common.
Yes, ma'am.
Dysgerminoma is one of the common dysgerminoma. Sex cord tumors, germ cell tumors are the ones they have to rule out.
Yes, ma'am.
Okay. Even
Ma'am,
okay. Yeah, tell me.
no, ma'am. Yes, sir. Please continue.
Okay. So then other factors which say that the tumor is benign.
Ma'am, on examination, ma'am.
Young age, slow growth, reproductive age, slow growth. Anything else in history? She does not have any loss of appetite or loss of weight.
Yes, ma'am. No,
Okay.
ma'am, no constitutional symptoms, and
Yeah. Then
ma'am, no symptoms of any metastasis like bone pain or any ascites.
okay.
Ma'am, and then there is no history of any hepatic involvement also. And
Okay. So okay, it rules out in metastasis. Then
and there is no history of any ma'am, leg swelling that can occur in the late stage metastasis.
and one more thing you were supposed to mention, lymph node examination. In you should in pelvic malignancy cases you should see lymph nodes, inguinal lymph nodes you can palpate easily. Other lymph nodes you won't be able to make out, but you should also see for inguinal lymph nodes. In head to toe you mentioned supraclavicular nodes, no? So
Yes, ma'am.
similarly, inguinal lymph nodes you have to mention.
Okay.
Okay. Then what are the risk factors? She doesn't. Menarche is at 14 years.
Yes,
Okay.
ma'am.
So she does not have early menarche.
Yes, ma'am.
Okay. And there is no history of infertility. That is
Yes,
also risk factor for malignancy. And there is no history of nulliparity. She is multiparous. So that risk factor is not there. Then
ma'am.
there is no family history.
Yes, ma'am.
Okay. Then she has breastfed. So what are the factors that decrease the risk of ovarian cancer?
Ma'am, early pregnancy, multiparity, and ma'am, oral contraceptive use, and
Yes.
ma'am,
OCP definitely decreases the risk for ovarian cancer, especially in cases of familial. There is a familial preponderance to tumors, ovarian tumors. They prescribe OC pills to prevent ovarian cancer.
yes, ma'am.
If there is family history of ovarian cancer, they should use OC pills for contraception and for prevention of ovarian cancer. So, okay, that is called chemo prevention.
Okay, ma'am.
Okay, then breastfeeding.
Yes, ma'am.
Okay, then
Ma'am,
has
ma'am,
she undergone sterilization? Your patient, has she undergone sterilization?
No, ma'am. She has not gone, ma'am, till now.
Okay, so tubectomy is also protective for ovarian cancer.
So,
So there is one new hypothesis that there are some abnormal cells from the fimbrial end of the fallopian tube,
yes, ma'am.
which can increase the risk of ovarian cancer. There is a new idea that the distal end of tube has the potential to give rise to malignant cells. Precursor of malignancy lies in the fallopian tube. So tubectomy is known to be protective for ovarian cancer.
Okay, ma'am.
Okay. Okay, fine. Then coming to examination, what are the things to suggest that this is benign?
Ma'am, on examination, ma'am, ma'am, the swelling was localized. It was smooth, cystic.
Unilateral. Localized means unilateral.
Yes, ma'am, unilateral. Ma'am.
Okay.
Ma'am, it was smooth, cystic, no, ma'am, mobile. It was not fixed with surrounding structures.
Yes.
Ma'am, and there
was no ascites.
yes, ma'am. No
Okay.
ascites.
Okay. Then
And then there were bowel
it
search.
is probably uniloculated. It is not cystic or multiseptated. Surface is smooth like a single tumor. It is It is
Yes,
not
ma'am.
multiseptate. That we can't make out on examination. I'm just telling you to remember. It is mainly seen on. It is an ultrasound feature. Sometimes you may be able to make out. Okay. Then there is no ascites. Then
Ma'am, bowel sounds were heard and normal. Ma'am, there was no associated history of, ma'am, there was no associated intestinal signs of intestinal obstruction.
oh, that is advanced stage of ovarian cancer.
Okay.
Okay. So okay, fine. That is not that you need not mention.
Yes.
That is seen in advanced ovarian cancer. They die of intestinal obstruction. Okay. Then POD, you have done provisional examination. In that you have mentioned.
Ma'am, there was no nodules or mass
Go to next slide.
present in the. Yes.
Yeah. There was no nodule in pouch of Douglas.
Yes.
What are those nodules, if at all you feel? They are the tumor deposits.
Yes, ma'am.
Okay. Okay, so these are the points favoring benign.
Yes, ma'am.
So, but you cannot exclude by these points. This suggests that it could be benign.
Yes, ma'am.
You still have to rule out. Okay.
Yes, ma'am.
Okay. What percentage of ovarian cancers have heredity are familial? Like
I don't know the percentage.
5 to 10%.
Okay.
Okay.
Yes, ma'am.
Okay. So, any doubts till now? Okay. Next, you tell me what all investigations you will do in this case.
Ma'am, I'll like to do, ma'am, ultrasound pelvis and abdomen.
Okay.
Ma'am,
so, what do you know with ultrasound?
Ma'am, I'd like to confirm whether it is the swelling is arising from the ovaries or not.
Okay.
Ma'am, and if it is a cystic swelling, then ma'am, what the type of cystic swelling, whether ma'am it is uniloculated or multiloculated, and if it is multiloculated, then the thickness of the septa, and if there is any extension or growth beyond the walls.
Very good. Okay. Then any papillary projection, solid areas in the mass?
Yes, ma'am. Any heterogeneous densities or any if there is any others any other heterogeneous lesions within the cystic swelling, or if there is any bilateral lesion, that I want to rule out.
Okay. Very good. You will look at the other ovary and also the uterus.
Yes, ma'am.
Okay. Okay, fine. You have seen it is a simple cyst. No septations, no loculations, no increased vascularity, no papillary projections, no solid areas. Okay.
Yes, ma'am.
How do you like to proceed?
Ma'am, I'd like to do certain other investigation, lab investigations, including including certain markers like carcinoembryonic antigen and CA-125 levels.
Okay.
Also, AFP and alpha fetoprotein and beta HCG levels. And then, because there's no signs of hormonal increase, I'll not go for the hormones, but
LDH.
yes, ma'am, LDH, ma'am. Yes, ma'am.
So LDH, alpha fetoprotein, HCG, CA-125. Okay.
Yes, ma'am.
And CEA. These are sufficient usually.
Okay.
Okay. Now what is your next step? CA-125 is 50.
Ma'am, if CA-125 is 50, ma'am, then I'd like to, ma'am, rule out other causes of increasing CA-125. And then, like in endometriosis or pelvic tuberculosis or PID and other diseases. And then,
Will it always be disease?
no, ma'am, it can be sometimes normally increased.
Menstruation also it will be increased sometimes.
Yes.
So 35 is the cutoff, but 50 is you near normal for a premenopausal woman.
Okay, ma'am.
Okay. Since the mass is more than 7 centimeter, you will proceed with surgery.
Yes, ma'am.
Okay. So what? Laparoscopy, laparotomy? What do you want to do?
Ma'am, I'd like to do, ma'am, given that this is a benign tumor, ma'am, I'd like to do.
Wait, we should do other investigations, no, routine, hemoglobin, platelet, blood
Yes,
group,
ma'am. Yes, ma'am. Yes, ma'am.
serology, LFT, RFT, ECG, whatever is required. Pap smear, okay, routine.
Yes, ma'am.
Okay. Then
Ma'am, after routine investigation, then, ma'am, I'd like to take informed consent, and regarding, ma'am, I'd like to proceed with performing cystectomy or ovariotomy, ma'am, if because of the benign nature of the swelling.
okay. So either laparoscopic or laparotomy, cystectomy.
Yes, ma'am.
Okay. So while you should also take consent for removal of ovary.
Yes, ma'am.
Okay. What if
Okay,
it was normal and when you open there was some papillary, there were some solid areas on the surface or some surface deposits, you might have to remove the ovary, right? So you
yes,
should
ma'am.
also consent for removal of ovary. Okay.
Okay, ma'am.
You will go with cystectomy, but if required, you might have to remove the ovary.
Okay, ma'am.
Okay. Are you supposed to know the scoring for ovarian cancer? Do you know of any scoring?
I know the, ma'am, FIGO staging.
Hmm.
Is it the same, ma'am, scoring? Or,
You know staging?
ma'am, I know the FIGO staging and the RMI risk of malignancy index.
Yeah, tell me what is RMI?
Ma'am, it is a score based on, ma'am, USG finding, then menopausal status, as well as CA-125 levels.
Okay.
Ma'am, the product of these three findings are found. In case of USG, certain findings like bilateral tumors or heterogeneous lesions or signs of malignancy, etc., are found, and the scores is calculated. And in case of menopausal status, whether it is premenopausal or menopausal, then in case of CA-125 levels in terms of international units per milliliter, the product is found out, and if it is less than 25, then the risk of malignancy is low, less than 2% or something. If in case of 25 to 250, then the risk is approximately 20%, and if it is above 250, then the risk of malignancy is approximately 75 or so, 75%.
Yeah. Okay. So it is used for referral. You can
Yes, ma'am.
assess and then you can refer if the score is high.
Okay.
It is not very sensitive. It is not very sensitive or specific. But
Yes, ma'am.
if you, it is one of the scores used.
Okay.
Okay. Okay. See, what is normal CA125 level?
Ma'am, less than 35 international unit per milliliter.
Yeah, it is normal in postmenopausal. 35 is the cutoff. For premenopausal, it can be increased even up to 200. So 50 may be normal for this patient. If it is more than 200 for premenopausal, you really have to worry. Whereas for postmenopausal, if it's more than 35, you have to think of malignancy.
Okay.
Okay.
Yes, ma'am.
Okay. And then,
Ma'am,
yeah, tell me.
I'm sorry, ma'am. I didn't understand the question, ma'am.
No. I was telling about CA125. If it is more than 35 in postmenopausal or more
Yes.
than 200 in premenopausal, it is abnormal.
Okay, ma'am. Yes, ma'am.
Okay. Okay. Did you follow up this patient? Was she
Ma'am, I couldn't, ma'am. After, ma'am, 1 week lockdown was given, so ma'am, I couldn't go for follow-up.
she would have been operated in 1 or 2 days.
Ma'am, ma'am, no, ma'am. They were waiting for certain investigations, ma'am. That's why, ma'am.
Okay. What is Meek syndrome?
Ma'am, in case of certain ovarian tumors like fibroma or tachoma, there is, ma'am, there is also associated with ascites and right-sided pleural effusion that is known as Meek syndrome.
Okay. What is pseudomix?
In case of other tumors like Brenner's tumor or rarely granulosa cell tumor, or in case of uterine fibroids, ma'am, if ascites and right-sided pleural effusion is also present, then pseudomix syndrome.
Okay. What is pseudomix?
In case of, ma'am, conditions like SLE, there can be polyserositis, which can result in ascites and right-sided pleural effusion that can mimic uh, tumors. That's why it's known as pseudomix.
Okay. So, do you know about borderline tumors?
Yes, ma'am. Ma'am, a subgroup of it is a subgroup of epithelial tumors, especially serous and mucinous type. In case in which there is, if that malignant part of the tumor is within the within the well localized within the capsule with less than 4 mitotic mitotic spindles seen per 10 hyperfill, then it is known as borderline tumor, and it is, ma'am, uh, it has good prognosis of about 90%, and conservative surgery can be applied here, even though it is, ma'am, malignant tissue is present.
Yeah, good. So they can have implants. They are not metastasis. They, apart from the primary tumor, they can have implants in the peritoneal cavity. But they don't generally metastasize, and they have good survival rates. Okay. 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 Do you do appendicectomy when you remove ovarian tumor?
In case of, ma'am, mucinous tumors, then, ma'am, then appendicectomy is also performed along with removal of the tumor because of uh, potential chance of seeding from the any mucosal in the appendix to the ovary. That's why is also removed along with it.
Yeah. Okay. Good. Very good. Everything you are answering. Very good. Okay. So how do you screen for ovarian tumor?
Ma'am, in case of ma'am,
How
if
do
there
you
is
screen
any,
cervical cancer?
ma'am,
How do you screen for cervical cancer?
ma'am, pap smear is done, ma'am, after 21 years of age every yearly, and if there
Not
is
every yearly, every 3 years.
every year, yes, ma'am. Sorry,
Okay.
yes,
Till
ma'am.
65 years.
Yes, ma'am.
Okay. Or HPV co-testing once in 5 years. Okay.
Yes,
So
ma'am.
this is how there is set guidelines for cervical screening.
Yes,
Likewise, what's the screening guideline for ovarian cancer?
ma'am. I don't know, ma'am, exact screening guideline, ma'am, but
No, yeah, correct. There is no particular screening guidelines for ovarian and endometrial cancer.
okay, ma'am.
Okay.
Yes,
Okay.
ma'am.
Okay. What is risk reducing salpingectomy? You know, like I mentioned, no,
Yes, ma'am.
in patients with hereditary familial ovarian cancer syndromes,
Yes, ma'am.
you can do risk reducing salpingectomy. You can just remove both the tubes completely. It
Yes, ma'am.
reduces the risk of tumor, and you give OC pills for chemo prevention.
Okay, ma'am.
In such patients, only screening is recommended.
Okay.
Transvaginal ultrasound with CA-125 6 monthly. Okay, only in patients with familial risk factors. Okay. Any doubts? Most of the things we have covered. Dr. Sindhu? Sindhu is there?
Yes, ma'am.
Dr.
Sindhu ma'am is there, ma'am.
Can't find her.
She has
Sindhu?
unmuted herself, ma'am.
Okay. Okay. Anything else? You would have been discussed about these cases, no?
Yes, ma'am.
So tell me any doubts you have?
There is one question in the chat section, ma'am.
Okay. What?
What is the risk factor for tumor in this patient? Somebody has asked, ma'am.
There may be no risk factor at all. Usually risk factors are seen for malignant ovarian tumors. Benign tumors, there may be no risk factors. It is often incidentally diagnosed.
Yes, ma'am.
Or they may present with mass.
Ma'am, Abhilash sir has joined, ma'am. Hello, Abhilash sir.
Hello. Sorry for late joining.
It's okay.
We covered most of the things. I can't recollect what we have missed.
Yeah, you're talking about risk reducing salpingooprectomy, right?
Yeah, I told them already once. I just mentioned once more. This is
What is opportunistic salpingectomy?
ovarian. Okay.
What is opportunistic salpingectomy?
Tapan?
Ma'am, in case of sir, if there is familial history of ovarian cancer,
No, that
or
is
in
risk
case,
reducing.
okay, ma'am.
He is asking about opportunistic.
Or prophylactic salpingectomy it's called.
The name itself suggests, just make a guess.
If there is in a case of menopausal women, perhaps if there is
No, see, earlier I think Mangala mentioned tubectomy reduces the risk of ovarian cancer, correct? No. So based on that, what they did was, whenever we have an opportunity, like maybe tubectomy or any other hysterectomy for benign conditions, they started removing fallopian tube.
Okay.
So that is called opportunistic salpingectomy. Okay.
Okay, sir.
Actually, the basis for this was from your risk-reducing salpingo-oophorectomy. From risk-reducing salpingo-oophorectomy specimens, whichever specimens they studied, they found that the cancers used to origin from the fimbrial end of the fallopian tube. That is called STIC, serous tubal intraepithelial carcinoma. Okay, STIC. So from STIC lesions, eventually ovarian cancer used to come. So based on that, they proposed opportunistic salpingectomy. Its evaluation is going on. The final results, we are not yet sure how much it reduces.
Okay, sir.
So when will you do risk-reducing salpingo-oophorectomy?
Sir,
in patients with the history of BRCA1 and BRCA2, when will you do? At what age you want to do RRSO?
I don't know, sir, the age.
Usually, whatever the age youngest had the ovarian cancer, before that you are ideally supposed to remove the ovaries, or at least once the childbearing is complete. Usually BRCA2 has lower risk of ovarian cancer compared to BRCA1. So BRCA2, 45 years they give on an average, whereas BRCA1 earlier, 35 to 40 years. Okay. And screening, do you know any method of screening?
That we discussed just now.
But the mode of screening we didn't mention. No? So screening is not done in general population, done in only specific, like BRCA1 positive patients. She didn't opt for oophorectomy. In those patients, you can go with the serial monitoring of CA125 levels or ultrasound. That is considered. There is an algorithm called.
We mentioned it already. Yeah, he mentioned RMI score and we mentioned the screening for high risk population.
Okay, fine.
Anything about benign ovarian tumors you want to talk about?
Complications were discussed?
No.
Yeah. What are the common complications of benign ovarian tumor?
Sir,
we discussed the causes of pain. Causes of pain in ovarian tumor.
Same thing constitutes the complications, right?
Yes.
Yeah.
Okay, just mention it up again. Enlist it up.
Sir, there can be torsion of a cyst. Then there can be infection.
Okay.
Then can be rupture.
Yes.
There can be secondarily it can change to carcinoma. It can be associated hemorrhage of the hemorrhage if the
perfect. Okay. So which benign tumors are more likely to undergo torsion?
Large cystic tumors with peduncles that can undergo torsion.
Okay. Is the commonest benign tumor we find in ovary?
Commonest is serous epithelial tumors.
Serous adenoma. Okay. So torsion, which which tumor is more notorious for torsion? Among all these, you classified, you discussed WHO classification already. So among those, which is the most common one to undergo torsion? Dermoid cyst, okay. Dermoid cyst has a solid component, no?
Yes.
That's more notorious to undergo torsion commonly.
Oh, okay, sir.
So you mentioned those tumor markers. Can you tell tumor markers for which tumor you are looking for?
Yes, sir. For epithelial tumors, mainly the carcinomembranous antigen and CA125.
CA125 is cancer antigen.
Cancer, yes, ma'am. Cancer. Yes,
Carcinomembranous is CEA.
That is for our bowel tumor,
Mucinous.
CEA. CA125, morely for any, it's actually any peritoneal irritation, it will increase. Maybe, okay, epithelial tumors then.
For this germinoma, lactate dehydrogenase, and then PLAP, and then in case of embryonal tumors, then we can go for alpha fetoprotein, alpha 1 antitrypsin, and beta HCG, especially for yolk sac tumors and dermoid cyst. In case of choriocarcinoma, there will be increase in beta HCG, and then in case of feminizing granulosa cell tumors, there will be increase in estrogen, and for for masculinizing tumors, there will be increase in testosterone. And
okay, fine. CA99, do you know of?
So I have heard of it in pancreas, but I don't know regarding
Mucinous tumors can have elevated CA99. Okay. What is the purpose of doing beta HCG? Is it only for like yolk sac, choriocarcinoma, or any other purpose is there for beta HCG?
for ectopic pregnancy.
Very good. Ectopic pregnancy also we have to rule out. Adnexal mass and HCG can be positive, right?
Yes.
Yes. I think management was also discussed, I think.
Yes.
This case was 11 into 8 centimeter.
So surgery is
Yeah.
during surgery, if you have facility, you have a suspicion of malignancy, what do you want to do?
So in case of if there is if malignancy is proved, then we then based on the surgical staging,
Not proved. You are just suspicious. You do not know yet. Okay.
You are in a good facility and you are just suspicious of malignancy. So can you do any other intraoperatively? Can you do some? Can you talk to your pathology
In
friends?
other terms, what are the things when you open for CA ovary?
Yep. Someone
What are the
answered
things?
frozen section.
if simultaneously frozen section biopsy can be done, and based on the result, then intraoperatively the surgery can
We
be.
can go ahead with the
fluid for
complete surgery.
cytology. You should obtain the fluid for cytology, ascitic fluid. If you are suspecting malignancy, okay, as soon as you open the abdomen,
Yes, ma'am.
okay, then you serially palpate all the organs to make sure that it is normal.
Yes, ma'am.
Then you look at the ovary, the contralateral ovary,
Yes, ma'am.
and decide and arrange for, if you have arranged for frozen section, then send for frozen section. And
Okay.
then you will decide further. Okay.
Yes, ma'am.
That's it.
Yeah, I think sufficient. Ovarian cancer we can discuss in another session. It will be lot if we discuss now only, no?
Yeah.
Yes.
Ovarian cancer may not be a UG case.
Oh no, they went till paclitaxel, carboplatin, chemotherapy in our UG exam. In the sense here,
Okay.
examiner.
Okay.
Including those.
Maybe
I was
the
surprised
student was
UG.
slow.
Yeah, she was very good. She answered full. including the dose of paclitaxel carboplatin.
Oh, okay.
But they can go based on your answering. You're answering very good, so they may go for ovarian cancer, staging, and further.
Okay, sir.
For Tapan's, they may go. Tapan's answering.
Yeah. And sometimes
Okay.
we don't get cases in the exam. No, ours is an onco center as well. We get most of the onco cases. CA cervix will always be there in the exam, and CA ovary operated case was also kept once for exam. For chemotherapy, she had come. So if your bad luck is there, then
No
cases may be
findings.
directly CA ovary.
If she had come for chemotherapy, there was no findings, or
No findings. Post-operative case. We told them how to
okay.
present. She came for chemotherapy, post-operative case. No case of CA ovary. Over. It directly goes only to CA ovary. But the questions will be UG level only. They usually don't go very high.
Yeah. Okay.
Only if you answer well, they may go for all this.
Okay. Not many
We'll go for
students
the
today.
doubts then.
Not many students today.
100 was the cutoff. No?
Is it?
Yeah. Kishan had posted only 100 can join. Others YouTube live streaming.
Oh, okay. Fine.
Okay, there is in the chat box there are few doubts. I think we'll go through it. What should be the screening test in case of a daughter if mother has ovarian CA?
Like we mentioned this, you should give OCPs for chemo prevention, risk reducing salpingo-oophorectomy, salpingectomy. See, if she has completed family, you can directly go for this salpingo-oophorectomy. Depends whether it is familial or not. You should assess
So I
whether
think
the mother
genetic
has got
counseling will be better.
Yeah, you should assess whether it is like familial. You should ask history of breast cancer in other relatives, ovarian cancer in other relatives, and what was the age of onset of ovarian cancer in her mother. If it points towards a diagnosis of familial cancer, then you can go for mutation testing. If she does not offer oophorectomy, then TVS and CA125 6-monthly. Correct, no, Abhilash?
Yeah, correct. If a mother is a known case of ovarian CA, how we go about same question was repeated.
Yeah, same. Not many doubts today. I don't know. YouTube. Okay.
Yeah, one question in the live stream. What is the relation between leg pain and swelling to ovarian cancer?
This also we discussed in history section. If DVT is common in ovarian cancer. So that is the relation, DVT. Can we use lump for this abdominal swelling? Yeah, generally we call mass per abdomen. No?
Lump is in the breast and mass is in the abdomen. That's what we were taught.
Yeah. Okay. You need not mention +0, Tapan.
Okay, ma'am.
How is it there?
That was I think he used a different notation. This is one more way of putting parity index in which they mention it as plus. Correct, no?
Yeah, I know. That is abortion 0.
Yes, ma'am. I tried to.
You can just mention para to live 2 enough.
Okay. Plus notation is not commonly used. There are very few people who use that plus notation. Maybe in your there they use it commonly. I don't know.
Okay, sir.
Anyhow, your examiners are comfortable. You have to present in saying okay.
Hello, ma'am.
Yes. Can we conclude the session?
Yeah, ma'am. Sir, can we end the session, sir?
Yeah, sure.
Thank you, Mangala, ma'am. Thank you, sir.
Yeah, sorry for late joining.
Tapan, well presented, Tapan.
Thank you, ma'am. Thank you, ma'am, and thank you, sir, for giving me the chance.
Very good. You have included almost all the points and you are very well prepared. Good. All the best. All
Thank
the
you, ma'am.
best to everyone.